Turn left. Keep right, and then turn right. Turn right. Exit right. Right, and then exit right. Exit right. Keep right, and then turn right. Turn right. Left.
satisfaction, and feeling like an expert in what you do. One thing that created a lot of burnout and angst for me was trying to get continued medical education right at the last minute. So why not join the CME membership and do CME while listening to this podcast? Go to psychiatrypodcast.com, sign up, sign in, take the test, and the certification is emailed to you in seconds.
Keep left.
All right, welcome back to the podcast. This is the first in a series I want to put together on borderline personality disorder. I thought I would start with a dialogue with two experts, Dr. Pro and Dr. Cummings. They bring decades of wisdom from working with this population. Dr. Pro runs a partial and IOP for men called Courage and women called Innovations at Loma Linda University, which treats trauma and has a bedrock of dialectical behavioral therapy. This program has a high percentage of people with borderline personality disorder who go through it. She is also the assistant program director of our residency and also runs the third-year psychiatry elective for students. She is known for her almost unstoppable energy, wizard-like intellect and knowledge, and mother-like love for all medical students and residents, which she's really dedicated her life to. Dr. Cummings, you probably know well from a multiplicity of episodes, is someone I consider one of the top 5 psychopharmacologists in the world. He has a new book coming out treating severe mental illness, and I myself have greatly benefited from his mentorship over the years.
Keep left.
So, for this episode, I'd like to also give a shout out to 2 medical students who worked tirelessly to do some prep before the episode was recorded, and then they put together with me an amazing handout along with Dr. Cummings and Dr. Pro. This is Bryce Thomas, who's an MS3, and Ben Robinson, who's an MS4. For this particular episode, they probably put in a couple hundred hours of work, just to give you an idea. So please check out the 14-page PDF on our website, psychiatrypodcast.com. Free thing that you can get in the resource library. All right, here we go. Welcome back to the podcast. I am joined today with Dr. Michael Cummings and Dr. Melissa Pro. You guys know Dr. Cummings well. He is a psychopharmacological expert that comes onto the show. And Dr. Melissa Pro is also one of, my mentors, someone who I look to for psychopharm wisdom. She also runs an eating disorder and a borderline personality disorder track in a partial IOP program at the University of Loma Linda. And so it was my thought to have her join us, especially for this talk on borderline personality disorder that we're going to have today. So welcome to the podcast.
Thank you very much.
Thanks.
Dr. Pro, just so my audience can further know, what exactly does your track entail? Just kind of, who is it for specifically?
We actually have 2 different tracks, a women's trauma program and a men's trauma program. The men's trauma program is called Courage, and the women's trauma program is called Innovations. They're both partial hospital program day treatment that steps down to intensive outpatient program day treatment. Both programs run anywhere from 6 to 8 weeks, and they are highly based in dialectical behavioral therapy, but also have other components built in based on the patient's individual needs, including management of substance use comorbidities and eating disorders comorbidities.
Awesome. And you've been doing this for how many years?
We built the program in 2011, so it's been a little while.
That's awesome. So 10 years. So Dr. Pro is someone who sees them weekly, gets them into the program, keeps them in the program, oversees the program, treatment team meeting, and someone who I learned under when I was a resident. So it's good to have you on.
Thank you.
Yeah, so I wanted to start today, and maybe Dr. Cummings, you can start and we'll kind of join in. Since we're talking about borderline personality disorder, maybe start with the history from your perspective of borderline personality disorder.
Let me start with, first off, a personal bias on my part. I keep hoping the DSM committee in this area will eventually update the nomenclature. the concept of borderline personality disorder dates back to the days when psychiatry was largely psychoanalytically oriented, and at first, indeed, because people with this disorder are prone to micropsychotic events, that is, distortions of reality when emotionally distressed, they were originally theorized to be, quotes, on the border of schizophrenia. Well, that turned out not to be true. These individuals don't, by and large, go on to develop schizophrenia spectrum disorders. I think the ICD-10 has the nomenclature a bit more correct at this point. In ICD-10, it is termed affective discontrol disorder, and that seems to be at the heart of this disorder. These are individuals who experience intense, often very negative affective states, which appears to then cause disturbances in interpersonal relationships, internal feelings of emptiness, and fears of abandonment, as well as proneness to suicidality, impulsivity, a whole range of things. The best research I've read was from some of the early psychology studies done back when behavioral psychology was in its ascendancy under B.F. Skinner. At that time, of course, people were theorized initially to be tabula rasa, that is, blank slates at birth. That subsequently turned out not to be true. And one of the studies that looked at that issue was a psychological study done by Strong and Chess, who evaluated infants at 6 hours of age and broadly characterized them into three categories. There were the easies. These were infants that, in response to novel stimuli, were basically approach not much affective arousal. There were the slow to warm ups, which were far away the majority of infants who would be somewhat hesitant with a novel stimulus, but then approach it. And lastly were the ones they called difficult. This was about 10% of their sample. Interestingly, they studied these individuals over a prolonged period of time, and for the most part, all of the people diagnosed as suffering from borderline personality disorder came out of that group with intense affective arousal. This is a disorder which occurs in about 1 to 2% of the population. The ratio is 3 to 1 female. It took a major step forward due to the work of Professor Marcia Linehan at the University of Washington in 1983 when she published the original treatment manuals for dialectical behavioral therapy, which focused on learning skills to deal with and take responsibility for labile, often intense affective states, and also taught people a variety of skills in terms of being able to manage their interpersonal relationships and tolerate their own distressing affect.
Okay, yeah, that's a good little history.
I'm just happy to listen to him talk. He can just talk the whole time, and I'm thrilled because he's my favorite thing, and he's awesome.
Yeah, when I think about the history of borderline personality disorder, I think about a comment on what you were saying about the psychoanalytic tradition. There's the psychotic and the neurotic, and they thought that the borderline was kind of in between the psychotic and neurotic. And psychotic doesn't, it's like a level of functioning as well. It's not just purely like schizophrenic. It's like a level of the way that someone is internally organized. So someone could be a psychotic, really depressed person, or they could be, so it's kind of like this in-between place is the way that I understood that. Would you say it differently, or is your understanding of that different?
I think that is accurate for psychoanalytic theory. I think the objection was to the original hypothesis was these people were not on their way to becoming more psychotic, and in fact most of them only briefly exhibit psychotic symptoms in terms of either overt symptoms or functionality. They certainly have a great deal of difficulty with interpersonal relationships and with functioning. They often do have a core lack of coherent identity. They don't have a good sense of who they are, and often I think that is their source of distress as well as dysphoria.
Yep. One thing I've pondered in thinking about the history of psychiatry is this diagnosis of hysteria, which was spoken about by the ancient Greeks, and this idea of hysteria being something that might have some overlap. I don't know.
Yes, hysteria actually, interestingly, by the Greeks was conceptualized to be related to the uterus, and indeed mostly it was women who were diagnosed suffering from hysteria. Essentially, these were individuals who indeed were prone to anxiety, in particular in the century when Sigmund Freud came along and was looking at individuals who were suffering from a variety of emergent symptoms and intense anxiety. Hysteria was a fairly common diagnostic term. That certainly blends into the idea of indeed people suffering from borderline personality disorder in the sense that they do suffer from intense affective states, including dysphoria and anxiety. They also, based on those affective states, do suffer from deficits in reality testing in terms of misinterpretation of the environment and of the motivations of others, either idealizing others or degrading them. One of my most articulate patients in this area was a woman who had undergone a great deal of psychotherapy, and at the time I met her was middle-aged and had largely recovered in terms of exhibiting behavioral discontrol. She was a university professor and told me that when she was growing up and was a child, someone asking her to pass the bread at the dinner table would set off in her a feeling of rejection, negative thoughts that they wanted her to starve to death, and consequently, occasionally, she would just blow up and stalk out of the room, mystifying, no doubt, the other people at the dinner table. That sort of interaction that often gives rise to a huge range of difficulty in these individuals' lives.
When I think about the different symptoms, I think about Gunderson's approach, like PISA, the P for psychotic, quasi-psychotic episodes, I for impulsivity, S for social adaptation, I for interpersonal relationships, and A for affect. And I was thinking we could go one by one through these and get Dr. Pro to tell some what this actually means in real life. And then maybe Dr. Cummings, you can chime in if you have anything to add specifically.
Sure.
So P, quasi-psychotic episodes, transient, fleeting, brief episodes persisting over the patient's lifetime, depersonalization, derealization. So I think about dissociation, rage reactions, paranoia, and yeah, Dr. Pro, any thoughts on how you see this?
Yeah, I think that oftentimes it's difficult to tell the difference between dissociation and psychosis, and as a result, patients get labeled as being psychotic when in actuality this is a dissociative state. And in a dissociative state, the patient is often not fully aware of the environment around them, to the same way where I might drive to work and not realize how I'm all of a sudden parked at work. And I know that my 8-minute commute happened. I know I didn't hit a person, that I stopped at all the stoplights, and if you asked me what color were the cars next to you, I would not be able to tell you that, but I made it to work. And a dissociative state is something that we all can get into at any point in time, but it's not to the point where it's pathologic. And a person with borderline personality disorder, when stressed, when triggered, oftentimes for no reason at all, can get into a dissociative state like that, except they also have emotional distress. And I've seen a patient with borderline personality disorder who was actually on clozapine for management because these episodes were so frequent and so intense, on the inpatient unit at the BMC, the behavioral hospital, take her forehead and slam it into very thick glass to the point where the glass broke. And in that episode, not even being fully aware of her surroundings or what was happening. And to the casual observer, this looks like psychosis. This is a person who is paranoid, responding to internal stimuli, etc. But more than anything, I think that this is really more of a dissociative state where this person is more closely in trance, not fully connected with all of their personhood, the same type of things that you see across cultures that have different presentations.
Yeah, that's good. That's good. So Cummings, how do you differentiate dissociation from psychosis?
Most of the psychotic illnesses, now certainly not all of them, a good example, psychotic disorder, of course, can occur in people with perfectly normal brains under intense duress. People can also become psychotic in response to psychotogenic compounds like amphetamines or phencyclidine. But in the case of most psychotic illness, and certainly the far and away the most common psychotic illness or schizophrenia spectrum disorders, you're looking at an ongoing disturbance in reality testing associated with positive psychotic symptoms like auditory visual hallucinations, paranoid delusions, grandiose delusions, bizarre delusions, ideas of thought insertion, thought withdrawal, thought control, along with negative symptoms, blunting of affect, inappropriate affect, and cognitive deficits. That's an ongoing chronic condition that is more akin to a developmental dementia. Whereas these people function normally much of the time, but indeed when emotionally distressed, it causes a disturbance in their reality testing and their perception of reality. As Dr. Perot was saying, rather than the more schizophrenia-like loss of reality testing, this is much more a dissociative state where the person may either feel that they're not real or that their surroundings are not real, cartoon-like. And once the affective storm, if you will, dies down, their reality testing fairly quickly returns to normal. In the more severe cases, indeed, second-generation antipsychotics over the last decade have become more commonly used in people with this diagnosis, including clozapine, for which there is good evidence that it can be quite effective, both in reducing the number and intensity of quasi-psychotic episodes, but also actually can help with modulation of affect, probably by enhancing glutamate signaling in the frontal lobe.
Yeah, Dr. Perot, this is like one of those questions that I'm like, how do you treat this? Like, is it acutely, I know in the psychiatric hospital, which you also spend half your year in, is it really the antipsychotics that you see working for the dissociation, or what is it that pulls someone out of the dissociation state?
So if we're going with dissociation occurs as the result of affective dysregulation, a person gets triggered, they go from I feel an emotion to I am distressed in seconds or microseconds, and then from that to a dissociative state. A lot of times similar to the management of a person that has acute psychosis that is in a fight or flight and trying to escape and more likely to be combative, secondary to not having perceptual awareness that's based in reality, you will do what you can to reduce that reactivity. And so if you can reduce the anxiety state to begin with, if you make it so that less likely to be anxious, to get overwhelmed, and to respond that quickly to a trauma, you can see reduction in the severity and in the frequency of these episodes. So more often than not, in the inpatient setting, we will start something that's going to enhance GABA. So something that is going to be calming while at the same time not necessarily cloud the sensorium. With these patients, we're never going to want to use a benzodiazepine if we can avoid it. That would be helpful just because of the huge comorbidity with substance use disorders. And so something like gabapentin, oxcarbazepine, these medications we'll use while we're starting other medications, and this at least helps the person to not get to a distress state so quickly. You can use PRN medications as well, and generally for PRN medications, there are a number of things, again, trying to avoid benzodiazepines, and we might use hydroxyzine, quetiapine. Really all you're doing in those cases really is anticholinergic sedating type of medications while you are managing them acutely. The goal is not to continue those medications long-term at all. But I think when it comes to the acute setting, management of these trance type episodes, these dissociative episodes, is to lower the overall state of anxiety on a minute-to-minute basis so that you're able to use other interventions and they can be successful. So being able to take a person that has tidal waves of emotion that come in and use all calming so that when those emotions coming on, they're smaller waves.
Yep. Yeah, I see in psychotherapy, I see two things very important. One is the mindfulness stuff that you guys teach in TBT to get someone to come into the here and now present moment. And also I would say the mentalization of mentalizing their own emotional states and then that of their provider, and then using a lot of empathy. Some patients respond to pure empathy, I've noticed. Like someone comes in with dissociation, you give them half an hour of empathy and they're completely back out of the dissociation. And I've had patients who I've tried some of the mindfulness stuff and they're like, Dr. Pewter, don't do the mindfulness stuff. Just be present with me. And I'm like, okay, I'll just try to do that.
I think for many of these patients that the empathetic support is highly valuable because of their difficulty with interpersonal relationships and their often intensely odd interactions with other people. That's rather off-putting for people around them, and they often feel very invalidated by their environment. So a little bit of validation often goes a long way. The other comment I wanted to make is that one of the things I want to be sure we underscore in this is that while a number of medications have been used as adjuncts in the text, there is no medication per se for borderline personality disorder. In the early 2000s, the SSRIs were popular because these individuals are prone to impulsive behavior. More recently, over the last decade, medications have shifted much more toward mood stabilizers and second-generation antipsychotics as adjunctive treatments. I think an important message for both clinicians and patients, though, is the answer to improving with this disorder does not come out of a pill.
Yeah, in regards to that, I wanted to get to later, but what I've found in like some of the big longitudinal studies of like mentalization-based therapy, for example, is most of the people are actually getting off of meds who get effective partial and who get effective long-term treatment much more than treatment as usual. And so I highly recommend for someone with this diagnosis to get into a good partial program. And that's why I think like the work that Dr. Pro is doing is so important, because not everywhere do they have a good partial program. Not everywhere do they do the necessary, training to learn one of the specialized therapies that works. And we'll get to later, maybe in this episode or a subsequent one, we'll go through all the different therapies that work. And I'm not sure that there's one that works better than another. One of the, there's a bunch of specialized therapies: mentalization, behavioral therapy, schema-focused therapy. All of them work very well. And when you compare them against each other, it's not like one is really standing out as the huge winner, to me at least.
Go straight on.
I agree completely. I think that in the partial hospital setting, the goal in that setting is to not even, at least from my experience, is not even to be focusing on the medication management, and if anything, to minimize the use of medications, because the actual treatment is going to be done in the therapy and in the continued therapeutic response. And I think the acute inpatient setting can have a different presentation, certainly, but the goal, I think, even over time, really is to reduce those inpatient hospitalizations by any means possible, so that you're not in that situation to begin with, where you're managing a patient with borderline personality disorder who's distressed in an inpatient setting.
Yeah, in general, hospitalization for these patients is at best a two-edged sword. It often is detrimental to them in the sense that hospitals are inherently a somewhat infantilizing environment, and can, frankly, in individuals who have a somewhat unstable personality structure to begin with, can induce an excessive amount of regression. I've treated a number of borderline patients who, while yes, they were impulsive, they had micropsychotic episodes, they had very troubled lives at the beginning of their introduction to psychiatry. Functional, they were working, they had a family. If they were hospitalized frequently, they often regressed to the point where they became non-functional. Because, and frankly, this is a characteristic of hospitals in general. We too often make people dependent and more infantile when we hospitalize them.
Yeah.
Exit right.
Okay, I do want to get through this piece of things, so let me go to the second one for the I. Impulsivity. So you'll see a long-standing behaviors that may undergo symptom substitution. Such impulsive things, self-regulation issues such as eating, drugs, money, gambling, promiscuity, mood regulation, chronic pain syndromes, somatic preoccupations. You have the self-destructive behaviors such as the self-mutilation, suicidality, sadomasochistic relationships, high-risk hobbies, high-risk behaviors, inattentiveness to care, to self-care, sabotaging relationships, and academic success. As I list off those things, Dr. Pro, does anything jump out as you as like, yes, I'm seeing this all the time, this is the secondary issue that we're trying to maybe not directly approach, but that improves? Are you approaching it directly? Are you hoping that some of the affect regulation leads to these things going down? Like, what's your general approach and what do you see?
So I'm a huge fan of good psychiatric management for borderline personality disorder, which was Gunderson's work, and I was lucky enough to go to a conference only a couple years before he died, where he was there going through it with us, piece by piece. And I really have seen a lot when it comes to maybe, yes, there's an underlying neurobiologic reason why these things are happening. There's circuitry in the brain that is not functioning the way that it's supposed to. But I think even more so, looking at this from a clinician's perspective, psychoanalytically, you have a person that is seeking a secure and connected space. And GPM looks at this as a person who looks to be secure and connected with others. And when they feel disconnected from others, when they feel insecure, when they feel invalidated, they move into a place that becomes chaotic, and then a place which becomes alone and desperate. And as a means of trying to get back to that connected place, they often engage in those behaviors. And whether those behaviors are dopamine seeking, whether those behaviors are seeking connection and attention from others, their brain is looking to feel connected and to feel safe. And these are the behaviors, in some ways, that are loopholes, where they're not going about it in a way that's healthy to get the connection that they need. They found a loophole to feel connected in the moment, but the downstream effects are further disconnection. And we're going to include a link for Dr. Darcy Trinkle, who goes through the cycle that patients have between connection, chaos, and feeling alone. And I think it's really a patient with borderline personality disorder that I treat. Watch this video. I have my trainees watch it. It's a really good overview of Gunderson's work, and it really does look at how to educate patients on this, because the majority of these behaviors oftentimes are occurring because this individual is seeking connection one way or another, seeking to feel attached. And these behaviors generally will get it done, which is why they continue to repeat this process, because it's been rewarded in one shape or another, and yet it is leading to the pathology just being furthered.
Yeah, I wanted to comment that indeed in Linehan's dialectical behavioral therapy, one of the major components of that was first in therapy groups teaching individuals skills for dealing with distress in terms of social situations. And then often those groups involve coaching, so that when the person's out in the real world and runs into a difficult situation, they often had resources they could call and very briefly ask their coach, this is the situation, what should I do? And that was a very pragmatic way of avoiding some of these loopholes and impulsive behavior. The other comment I would make is this is one of the strongest reasons not to use benzodiazepine in a borderline individual. Yes, acutely it will calm them down, but at the price of worsening impulsivity.
Yeah, two things. When you think about Marsha Lanaham's DBT, one of the things she does is actually gives out to each patient, has a way of contacting the therapist. And when I was at a conference she was speaking at, she said this was so important because she would have people call her, and she wouldn't have lengthy, half an hour conversations with people. It would be very short, like 5 minute, 10 minute. Okay, what skills are you using? Okay, I'll talk to you more about this in group tomorrow. But it's that connection that seemed to be really important. And I see that in all of the therapies that seem to have worked, is that there's an intense connection going on multiple times a week in these groups, in these relationships with these therapists. Mentalization, they trained nurses actually to perform a lot of the therapy. And it's that intense connection over time that seems to, in my mind, really help these clients get better. Okay, let's move on to social adaptation. So we have PISA, P-I-S is social adaptation. And Dr. Cummings already talked about this, how there's this ability to bring together their life in such a way that they can look normal to a lot of people. So they have this superficially intact social veneer, and their high performance, maybe only what their colleagues see, right? So this is kind of like, you could have someone who maybe is struggling with this and you just have no clue, because outwardly they just seem to have it together. This seems to erode with high stress, illicit drug use. In higher functioning patients, it seems to be that they're if you are an authority figure, they will pull it together for you in particular. So some of my front staff used to tell me this person is like belligerent, and when they get in my office, it's like I would have never known, you know? So Dr. Pro, any comments on this? Anything that you've seen? Because I know you've treated a lot of physicians. I mean, Dr. Pro treats probably 100, would you say 100 physicians at this point? Okay.
Keep left.
So, yeah. What do you see? Social veneer.
And 100%, I was literally, as you were saying that, I was thinking about a few physicians that I treat that very strongly have borderline personality disorder and yet are very successful.
Finding
And,
a new route.
you know, some of this just has to do with the
Go straight
chronic nature of the disorder and the fact that you have a person that has a brain that is not functioning in a normal way necessarily, where there is heightened distress
Reroute.
and their ability to manage that distress is poor. And yet at the same time, this can be a person that is very adaptable, that can easily sublimate, that can connect with other people, that is able to take a lot of the things that may come with the condition and use them for good. When I talk with patients about borderline personality disorder, I will often explain there is a lot of good things potentially that come with a
Go
person with
straight on.
borderline personality disorder. You can take a person like this, leave them in Detroit or, you know, somewhere entire life and say, I'll see you tomorrow. And by the next day, they will have a place to stay. They will have found people to help them out. They will have been able to make their needs known. They are adaptable. They are quick. They are able to bond with others. They can read others very well. There's components of this that over the course of time, just being able to adapt and deal with this brain, they've been able to pick up additional skills. And if you can highlight those things and subtract out some of the more detrimental aspects, you end up with a person that's very capable. And having treated a number of physicians with borderline personality disorder, it's very clear that you can see evidence of these behaviors there, and yet at the same time, they still have a beautiful intact frontal lobe that plenty of the time is able to, you know, use other processes rather than simply respond in distress. But it comes down to, you know, what has been the reward for that. And in some settings, in some patients, the greatest reward has been, you know, being in a state that was dependent. But you can definitely see people that are very, very high functioning and have this disorder and yet be able to control it most of the time.
Yeah. Dr. Cummings, any thoughts? Social adaptation, social veneer?
I would agree. Many of these individuals do manage to maintain a social veneer, often at very large degrees of effort on their part. And, you know, we see them, of course, when these things break down. I think what's important to address here is that many clinicians in the community in general are quite pessimistic about this disorder. And that's frankly one of the reasons I would like to see the name changed. Somehow, oh, they're borderline has become, for many, a pejorative statement. These individuals, contrary to those who have been kind of exhausted by treating some of these individuals, the recovery rate's actually pretty good. Now, in part, that's influenced by the fact that this has one of the highest suicide rates, around about 10%. But by the time these people reach middle age, about half of them no longer meet the criteria for borderline personality disorder.
I often don't tell clients when I think they're borderline or have borderline traits, unless I feel like it's going to help them engage treatment in a way that would be helpful. So if I'm trying to convince a person why they shouldn't smoke weed and why they shouldn't be on benzos, you know, then I might pull out the diagnosis, or why they need to go to a partial program, or why therapy is going to be helpful more than medications long term. Then I think actually having the diagnosis gives them a sense of power and like, okay, I could actually make some choices here that will make this not something that's like forever diagnosis and forever disease, you know?
Yes. Well, that's where I think, frankly, my own opinion is that the term personality disorder, I think this is an affective disorder, an affective dysregulation disorder from which people can recover. It's not a sentence to a lifelong maladaptive personality structure.
And I think that the neurobiologic basis of the disorder is something important to highlight with patients, that this is not simply a problem with your personhood or personality. Many patients with borderline personality disorder will carry and hold very strongly to a bipolar disorder diagnosis. And when you talk with them and try to gain more insight into why they're holding tightly to the bipolar disorder diagnosis, when once you've assessed them and had time treating them, you realize, no, this is not bipolar disorder in this individual. Looking at a diagnosis like bipolar disorder can help them understand why episodes come on without any kind of warning, why they may behave in ways that don't make sense to them, why their brain does things that are strange or bizarre or nonsensical when it's not aligned with their values. And I think being able to describe this with patients and to be able to go through with them and say, this is a disease that is in the brain. This is something that is heritable. This is something that you can see has structural, functional abnormalities and is something that is very, very treatable. I think being able to provide some of that education for patients ends up being really important, because then it doesn't just sound like and broken, and instead gives them some of what they're looking for in, there is something wrong in my brain in the way that I'm interacting, in the way that I'm acting, in the way that I'm behaving, and I can't put my finger on it, so it must be this thing. And being able to convert it into, this is a different disorder that can be very disabling, and at the same time is something that has a neurologic basis. It makes sense why this is happening, and there are options for care.
Yeah. Very good. And with the social adaptation, I think one thing I would add is it's helpful in the diagnosis of this, because someone who's psychotic will be psychotic around a multiplicity of people and situations. Or someone who's truly manic, it's not like they can pull themselves out of the mania and then appear normal to one person, and then the next moment they're back to being manic. So I think it's helpful to sort of see the social adaptation from social veneer as like part of the piece of the diagnosis, which can help you make sense of it. Okay, PISI, so I is for interpersonal relationships. So these are often chaotic, unsatisfying relationships with others, sometimes socially superficial, aloof, detached, but close relationships are often extremely intense. There can be some dependency in them. They can have some intense fears about being alone and rage with a primary caretaker. Sense of pervasive aloneness, and they can find themselves victims in certain relationships, being preyed upon by predators. So yeah, any thoughts, Dr. Perot, on how you see this and how you coach people to be more maybe healthy, or how do you approach this without someone feeling shame, I guess, is one of my questions.
I think for me in this treatment is being able to highlight that intense need for feeling connected, for feeling attached and feeling safe. And exactly as you were noting with patients, that empathy between the treatment provider and the patient is so valuable and oftentimes a very easy thing. When I'm talking with residents about how to work with these patients, how to help them toward insight, I start by asking the resident, do you like this person? Is there anything about them that you can see and value, or do you just clearly want to run away from them? And if the resident says, I want to run away from them, I said, then this is never going to work, because if you're not able to highlight something about them that you care about or you want good for them, they will feel that in you, and you will not be able to bond them or connect them. But if you can bring forward the parts that really do want to help protect and empower this person, they will detect that, they will bond with you, and then you can bring them toward that insight of, this is what connection looks like, and the reason why things went terribly wrong yesterday afternoon, where you overdosed on all of your medications. Partner told you that they liked what you were wearing that morning, and you had no idea why that led to that action. this is because you have issues with those connections, and sometimes feeling too close of a connection with another person can lead to them becoming dysregulated. Sometimes feeling a person pulling away can make them feel dysregulated. They have a very, very highly attuned systems to that feeling of connection, and the connection is vital to them on a day-to-day basis, and many of their behaviors are happening unconsciously when they feel that connection shift, especially if somebody's pulling away from them. And many of those behaviors that are maladaptive are occurring to try to get that connection back. And I think that being able to show how many of their behaviors are the product of that lack of connection is important, which is where some of the DBT skills work is valuable. Being able to do chain analysis, looking at here are all the pieces that led up to this thing that happened yesterday, and here are the places where feeling disconnected led to additional behaviors.
Very good. Dr. Cummings, any comments, any thoughts?
Yeah, I think one of the things that it's important for someone working with these patients to realize is that when we talk about them having intense fears of abandonment, from their perspective, because they have a sense of themselves, that often means that if the other draws away or threatens to abandon them, they're faced with intense feelings of emptiness, which is frankly a very scary place for any human being to be. And if people can get sort of past the chaos that sometimes comes with these patients, I think a good rule of interaction is the more chaotic the patient becomes, the calmer the therapist needs to be in responding to that empathetically.
Yeah, I think if you look at a lot of the therapies that work, it's like relationships are part of the cure, probably a majority in my mind of the cure. Despite, there's these brain circuits that we've identified, we'll talk about later, there's a heritability to this. There is a relationship cure to it, which is, it's a little bit confusing to some people because they think, if there are brain aspects, then isn't the, how does the therapy interact with the brain? And, our brains form in relationship, right? And our brains form in attachment. So it sometimes takes a little bit of skill to work with this population. Part of what I can see in DBT and in mentalization, transfer focus, a lot of it's like, how do you understand them to a point where you're not feeling of the different things that come up in the work that you do. And I think one of the big things that I see for success as a therapist is how do you deal with your own reaction, your own countertransference. That's like something I keep coming back to, is like, it's fundamental, it's important. And
indeed, one of the elements in almost all of the therapies designed for this disorder have been that the therapists in turn need a support system, to and including formal meetings among the therapists to support each other to decrease burnout. Working with these patients can be affectively intense, can essentially require the therapist to be on their toes and thinking, and frankly, it can be difficult work at times.
Okay, the last one is affect. So PISA ends with an A, so affect, chronically dysphoric and or labile.
Keep left.
So one question is, since adolescence, what % of the time have you experienced a normal mood? By that I mean no anger, emptiness, anxiety, or depression, for which they often answer somewhere below 20%.
Mm-hmm.
There's also chronic passive suicidality dating back to adolescence that we often see. Which, if you want to ask one question, have you felt this chronic passive suicidality? When did that start? And they usually say somewhere around. Dr. Pro, what would you add to this, or how would you sort of bring this to life a little bit?
I think that this is a perfect segue into those abnormal circuits. in the brain when talking about the affect and the affective dysregulation. So often it's easy to see patients with borderline personality disorder and their behaviors as manipulative, as being done intentionally. And while, yes, I'm not going to take away a person's agency, at the same time, if you think about any of our brains when dysregulated. So if all of a sudden I received a text from a colleague and it said, guess what, I'm not going to cover your vacation next week like I said I was going to. What my brain is going to do is going to go into a sequence of I'm feeling upset, I'm disappointed, I'm angry. I might want to text them back and say something rude. I might want to text a colleague and, complain to them. In that state, my brain is effectively dysregulated. I'm not in charge of what's happening in that minute. I can decide how I want my actions to go next, but I have a brain that is more under my control in a lot of ways than those with patients with borderline personality disorder. Not to say that their brains cannot be rehabilitated and trained in that way, but at baseline, especially earlier in the illness, you can see that affective dysregulation occurring often, frequently, and over much, much smaller things. Not somebody saying your vacation is canceled, but somebody simply didn't respond to the text as quickly as a sequence of affective dysregulation that occurs that it really is outside their control. And so what they do and their behavior certainly is within their control, but that affect, those feelings that become not just emotions but distress so quickly is not within their control. And that's something that's very important, in my opinion, to highlight.
Turn left.
Mm-hmm. Yeah, I want to add to that in this one meta-analysis where they looked at the brain of people with borderline personality disorder, what they found was that they had heightened activation during process of negative emotional stimuli in the left amygdala, left hippocampus, and
Keep
posterior
left,
cingulate
and then
cortex,
turn left.
as well as diminished activation in the prefrontal regions.
Turn
So this
left.
was shown across multiple studies, 281 people. So there's something going on when they get very stimulated. Their emotional centers of the brain are reacting more than the frontal lobe. The frontal lobe can be seen as kind of a, putting thoughts to things.
Turn
So
right.
this is where in DBT they have wise mind is the combination of the emotional centers and the thought centers. If you put those both together, they try to integrate those in
Make a
DBT.
U-turn.
So that's kind of like trying to integrate this more limbic response with a more thoughtful response. You put those together, you get wise mind. In mentalization, what they believe is that when someone gets physiologically aroused, they go into something called psychic equivalence mode, which is the reality. So you can think about like when you get in an argument with your spouse, you may think this person doesn't love me in this moment, but at the same time, you're usually thinking, yeah, but they do, and this, and I'm just having this argument. With someone with borderline personality disorder, when they get in this sort of psychic equivalence mode, the reality that they think in their mind is the reality for that moment. So despite whatever you're believing or thinking or saying, they believe that you are thinking something about them, often something very shame-inducing, something very isolating, or making themselves feel very alone. They believe that is the reality that is going on. So physiologically, they have to come down before they can start to put some to start to be able to think that you might not be thinking what they believe that you're thinking. Okay, so that's what this kind of affectively charged brain is doing in that heightened state. Dr. Cummings, I'm sure you could wax poetically about the
Turn left.
MRIs, the functional MRIs. I don't know if you have anything to add to this.
Yes, these are individuals indeed who have an excessive amygdala response, particularly in the dominant temporal lobe, and that essentially translates into intense fear, intense anger, underscore and
Get ready to
capitalize
turn
intense in both cases. In turn, the overactivation of the hippocampus
Turn
and
right.
parahippocampal complex is related to the distortions in reality, the dissociative states that these people experience. People have actually found that the hippocampus and parahippocampal structures are smaller in people with this disorder, likely due to chronic exposure to cortisol, because they spend a lot of time being sympathetically aroused. The prefrontal cortex, in turn, is hypoactive, hyporesponsive in these individuals. Consequently, they don't have that ability to top-down modulate their affective state as effectively as other people do. One of the interesting things that all of these therapies have in common is that they essentially appear to cause a process called initiation and adaptation in these neural circuits, so that with repeated therapeutic episodes, the functioning of these areas of the brain move back toward a more normal homeostatic status. It's an interesting thing that's been of interest to me for some time, is that psychotherapy is essentially a way to perturb the functioning of the brain, just as medications are a way to perturb certain neural circuits. Essentially, I think both are hitting on the same underlying biological processes.
Yep. There was one large-scale population study done in Sweden. So they looked at 1.8 million individuals. This just came out in 2021 by Skoglund, and they had 11,000 individuals diagnosed with borderline personality disorder in this full population. So that's 1.1% of females, 0.2% of males. And they found, when looking at the familial association, that people who were more related had a stronger link. So for example, monozygotic twins, the concordance rate, so if one twin was diagnosed with borderline personality disorder, the concordance rate that the other one would also be diagnosed was 7.4%. Whereas dizygotic twins, it was 4.2%, full siblings 2.5%. So they put the heritability estimate at 46%. Now I know this varies in different studies, but I think it's good to put out there that this is 46%. What does this actually mean, heritability-wise? Bipolar estimates are around 60, schizophrenia around 73. Schizophrenia has a concordance rate of monozygotic twins at 33%, so it's very genetic. ADHD, 71% to 73%. Height is around 90%. So when you think about this, Dr. Cummings, my question for you would be like, any nuance that you would put here? I know we've talked a lot about genetics and biology, but it seems to be about 50-50, environment a little bit.
Yeah, my reading of the data is that, as in the Strong and Chess study way back in the 40s, the underlying biological substrate, that is the tendency to experience intense affect, is there largely genetically. I don't think anyone would argue that at 6 hours of age the environment had yet had a major influence on most of these infants. But that genetics, of course, is born into an environment that then begins to shape the brain, and in a certain percentage of these individuals who have the underlying biology, they go on to develop a disorder, which we've either named it borderline personality disorder or affective dysregulation disorder. My guess is the ones who do not gain a clinical diagnosis may still be affectively intense people, but ones who are better at modulating their affective responses, and consequently they don't fall into some of the impulsive and socially disastrous patterns of behavior that the persons that we see have.
And can you speak at all about the epigenetic nature of the illness?
We barely are beginning to understand epigenetics. In fact, everyone was somewhat dismayed, I think, in the genetic community when they figured out that not are involved in a particular illness or in the underlying propensity toward a particular illness, but genes spend a lot of their time talking to each other. And genes will either increase or decrease the activity of other genes, which is a hugely exponential process, and likely, however, underlies many of the adaptations that occur in response to the environment. One of the things that Dr. Peter was saying that is absolutely correct is we are born with a very plastic brain. We have certain genetic propensities and epigenetic propensities, but by and large, our brain is made to interact with the environment. And there've been a number of studies suggesting that if someone with the underpinnings for this disorder is born into a hostile, rejecting, neglectful, abusive environment, it increases the probability that they will wind up with a clinical illness. Whereas a positive, nurturing, empathetic environment, starting with the same biology, tends to decrease the pathologic outcome.
Yeah. There's a study that came out in 2021 I shared with Dr. Pro. ARENS 2021, where they found that epigenetic alterations more frequent in genes controlling genesis and cell differentiation, which may be modified by early childhood trauma. So these early childhood events, trauma, modulate the magnitude of this epigenetic alteration that we see in these genes with borderline personality disorder. So it seems like there's this change that goes on, and I think from what I was reading, there's a lot of stuff that's just not known at this point, and I'm sure this will be a place of continued research. And this type of research, I think, is pretty hard to do because it's probably pretty expensive.
Very difficult to do, and frankly, very difficult to understand just because of its complexity. We have about 10,000 of our genes are involved either directly or indirectly in brain development and brain function. And if you have 10,000 genes that talk to each other, we're just barely at the beginning of being able to understand what those gene-to-gene conversations mean, basically. But it will be a rich area of research because I think as we understand it more, we will have a better handle on what goes wrong and what influences both the adverse effects in the environment and, frankly, also makes potentially our psychotherapies more effective.
Yeah. I was looking a lot at attachment to kind of put out some of these things and get your perspective on this, Dr. Cummings and Dr. Pro. There was one prospective longitudinal study done by Carson in 2009 where they followed 162 infants who became adults, and at 28 they looked at them again. So this is a pretty long and probably rather difficult study to do, where they found that borderline personality symptoms significantly related to relational experiences, attachment disorganization at 12 months, maltreatment at 12 months. At 42 months, maternal hostility had an R of 0.42, and this sort of early malevolent experience seemed to be pretty strongly associated with future borderline personality disorder. Family disruption and related to the father's presence, family life stress. At age 12, emotional regulation and issues with self-representation were highly linked. Any thoughts on early childhood and how this plays and what specific environments lead to people having more of these issues that we're talking about?
Well, it seems clear from this and from earlier studies that childhood adversity in terms of growing up in a chaotic environment is associated with the loss of confidence in connectedness that Dr. Perot was addressing earlier. Many of the things that cause these people to be so desperate and to do things that are inadvisable, seeking connection, is related to the fact that their early environment was chaotic, it was unpredictable, it was often punishing. You know, you do X and you get praise one day, you do X the next day and you get punished. If you're a young brain trying to figure out the world and what works and what doesn't, that makes that virtually an insurmountable task. And you see that then reflected by these individuals in terms of their relationships with others, where they will either idealize the other. Oh, you're absolutely wonderful, you're perfect, you'll take care of me, I know this will be absolutely wonderful. And then, of course, as soon as the other individual screws up or is perceived to screw up in some way, their response is, oh, you're terrible, you're awful. You know, it's a very black and white interpretation of the environment, often because their environment was very black, white, chaotic, jumbled. You know, one of the chief things that young humans try to do is figure out how the world works. That's not very easy to do in an environment where the rules may change not only from day to day, but from minute to minute.
I think for me, a lot of looking at the new data and looks at how this presentation comes about, you get to see some of the myths come undone. I think there's, as mentioned already, you know, there's huge stigma associated with the diagnosis. And I think 20, 30 years ago, there was a belief that these are people that have had some kind of trauma, there's something broken in them, and you just have to wait for it to burn out or for there to be the logical progression of the illness towards suicide. And there was a lot of stigmatization of these individuals and practitioners giving up and just saying there's nothing that can be done. And I think with more data that comes out, with more understanding of heritability, with understanding the circuitry of the effects of therapy, you're able to see you can have an individual that had no trauma whatsoever early in life and still can manifest with these symptoms. And I think for me, treating physicians that had very clear symptoms of borderline personality disorder yet had no adverse early life experiences made me first begin to look at that data, because I was like, I looked and I looked and I looked. However, I can find through tracking, I can find a parent and or a grandparent that had substantial amounts of trauma and had very clear manifestations of this illness. And this is something that there is changes in the brain throughout the course of life that can then be passed down. And understanding that component is important not only for education of the patient, but also just as practitioners. That is not cut and dry. This is not something where you just need to figure out what the trauma was. In addition to that, the knowledge that a lot of these therapies are leading to structural and functional changes in the brain that can be seen on fMRI. For me, that gives me so much hope, and is one of the reasons why I love treating these patients, because over the course of time, you can begin to see new skills emerge and new abilities to correct and new abilities to regulate, improved ability for portions of the prefrontal cortex to come online, and the person says, what are my values right now, and what do I need to do about this? This is how I feel, but I don't need to act on how I feel right now. And to get to see a person's brain begin to do that over time, for me, is one of the most rewarding aspects of working with these patients. And knowing that as long as a provider, I hold these things at the same time, I can have more hope for their care, and I can impart some.
Yeah, I just want to give the study to that. Goodman 2014, dialectical behavioral therapy was found to attenuate amygdala hyperactivity at baseline, which correlated with changes in measures of emotional regulation and increased use of emotional regulation strategies. So the cool thing about how the brain interacts with therapy is that the therapy and the partial and the sort of like this repetitive work that's being done is actually changing the brain. It's so hopeful to me. I love that the book, how the brain that changes itself. It's like the story of how the brain can like change over time, and it's not like this static thing that's like never changing. So I don't like the idea of personality, because personality seems chronic and unchanging, where it's like, no, this actually can change. Like, you can learn how to emotional regulate. It's hard, Like, doing the work is hard. It is very, very hard. But knowing that there is hope is encouraging to me. And I like what you said, Dr. Pro, that it's not like a singular trauma, that once you get through the singular trauma, this person's going to be different. It's I think that there's this sort of fantasy, and maybe there's a couple cases where this happens. This one person works through this one memory and then it's all better. But because it's so much attachment related and stuff, it's going to be through attachment that change occurs. Attachment takes time. Attachment is hard work. You're in the trenches. You're working through your own countertransference. You're working on staying empathic when your own stuff gets stirred up. So you have to do your own work as you help people, you know? And so it's a hopeful message that I hope we're putting out here, but also a message of the reality of like, okay, this is actually like something that's very difficult to do. And we have to fight insurance companies, which is even maybe our countertransference towards the insurance.
Rerouting.
Countertransference towards insurance companies is worse than my countertransference towards patients at this point. Smile over there. You're like, yep.
I agree. I have to do a reframe and just remind myself that there are people in places that will abuse any system, and that this exists as a result of that abuse, and that I have to accept these limitations. If I don't reframe it that way, yes, I will lose my mind.
And how many docs to doc do you do a week? Or
probably 4 or 5, and that's better than what it used to be.
So if you're listening to this and you fantasize this idea of becoming a psychiatrist and this sort of glory that we get to do, also know that there are thorns in our side, right? And it's often the people that we can't treat. The people who are making the decisions, like there's a quota and we can only allow so many days before this quota gets done. And so like there's certain times of the year that the quotas sort of get tightened, right? What are the worst times of the year? It's like
October
to December.
The last quarter.
They're like, okay, finally we have to start saying no because we can only give so many days. Okay. Well, I want to make sure that we hit any points in this thing that you guys really wanted to hit on this. So Dr. Cummings, as we're sitting here, as we're talking about this, anything that we haven't spoken about that you really want to say, and then Dr. Pro asks you the same question.
I think I just want to reiterate something that you said, that this is a disorder. However, it is not a hopeless diagnosis. It is rather hopeful. There aren't many other conditions we treat where half of the people recover and essentially no longer meet diagnostic criteria.
Or like the mentalization data, which I'm probably most familiar with. It's like 83% 6% after.
Go straight on.
So they did treatment for 2 years and then they followed them for 5 years. Like 86% did not meet criteria for borderline personality disorder. And most of those people were off medications, which is like mind-blowing if you think about being in the trenches. The thing about if you're a resident out there and you're like, really? That just doesn't make sense. It's because you're seeing the patients who are coming back to the hospital. You don't see the patients who are doing better, which is part of the problem of not being able to follow patients longitudinally until you get out of residency for years and years. It's like you don't see the good cases of like, oh, this person got the treatment and this person's doing well and they're at this other place in their life. No, as a resident, when you're in the trenches or if you're an inpatient doctor, you see the people who are continually struggling, continually not getting or in the process of getting the care that they need to overcome. So I think that's another piece of hope I would give you out there if you're in the trenches. It's like consider that you're part of the solution, a small part, and if you can do your role to the best of your ability, it'll give the best chance that this person will have that long. Remarks, closing thoughts?
Yeah, I would definitely say check out Dr. Trinkle's video, check out the Good Psychiatric Management Handbook for clinicians. The thing that I find that's the best about this way of management is it doesn't have to pit mentalization versus DBT versus other. It says all of these things have good evidence, all of these things can work. Here's how you can incorporate them as tools in managing patients under a larger framework. And it gives a lot of really good ideas on how, as a practitioner, you can interact with a patient when a patient is being rude or nasty or manipulative. And so it is a modular approach for a clinician who's going to be managing these patients long term. And as a person where 30% of my patients that I work with have really, really severe borderline personality disorder, it's something that has helped me to change the way I engage and interact with patients, and it's provided a lot of support for the way that I think about the disorder. And as Dr. Cummings has said, make sure that I've got a team working with me and not doing this on my own, because this is very, very difficult. But I think that having information and resources like these are good, and I think that having a team is one of the most important things to make sure that I don't get lost in this. And so even if it's just outpatient, me and the therapist being in close contact and texting or calling once a month or every few weeks just to touch bases, then we're on the same. And if there's something I'm struggling with or frustrated with on the patient, I have someone to talk to who may have similar struggles, and by the time we're done discussing it, we both feel better and we're on the same page and we're ready to go after this and help this person. So I think doing this alone is one of the greatest reasons why people get burned out from the treatment.
Yeah, not that my program is for this population, but we often see people with medical issues with borderline personality disorder, and one of the things I've had to do as the medical director is to notice when there's some splitting going on, and to see it in the context of, okay, this person is recreating the chaotic interpersonal world of their childhood in this treatment team. And so, just like mom and dad were yelling at each other at times, now that, this therapist and the psychiatrist, they would be best yelling at each other. So they're going to try to recreate the chaos. And so to say that might be going on, and then to empathize with how that's playing out in the team, I think is very, very important. I think you run a really good team where you have a lot of cohesion, Dr. Pro, and that's probably been a huge point of your success. And, I just want to compliment you in that way. I've always appreciated seeing how you create the cohesion in your teams. And I think that's just huge.
I am definitely grateful to have this as a resource in this region. A specialized DBT treatment program is not a part of every partial hospital program. It certainly requires more staffing, more, and at the same time having this service to offer to the region, I think is wonderful, because there are so many patients in this area that are in need.
Very good. All right, guys. Well, thank you so much for taking the time to come on. I'm sure my listeners will appreciate it. If you want the notes, go to the resource library, and in the PDF, I'll put in the links that Dr. Pro talked about. So you can psychiatrypodcast.com or follow the show notes to that. And we'll leave it there for today.
Okay, thank you.
Thank you very much.
.200 new worlds and a song inspired by them this week on Planetary Radio. Welcome. I'm Matt Kaplan of the Planetary Society with more of the human adventure across our solar system and beyond. Someone has to keep track of the thousands of exoplanets discovered by TESS, the Transiting Exoplanet Survey satellite. That person is Natalia Guerrero. Natalia is lead author of the brand new paper announcing those new worlds. She'll talk to us about this great science and also about how it inspires much of her dramatic, musical, and radio artistry. We're also going to She is tracking the tail of that Venusian phosphine. New yet very old data backs its existence.
Exit right.
I also have an especially good time with Bruce Betts this week, so I hope you'll stay for What's Up.
Turn right.
As always, we're grateful to all of you who listen, grateful to those who write to us, and extraordinarily grateful to everyone who leaves us a rating or review in Apple Podcasts. I hope you'll consider helping us out this way if you haven't. I don't know if it's a moonrise or a moonset. Either way, it's like none I've ever seen. It's that Martian moon Phobos peeking through the clouds above Mount Sharp in a photo snapped by the Curiosity rover. You'll find it at planetary.org/downlink, where it is followed by these headlines and much more. As some expected, the Biden
I did it all on my own, no promo. I got fans getting tats on my logo. I remember when nobody came to my shows, but I kept coming back like a yo-yo. In high school, they would laugh, try to label. Eating lunch with nobody at my table. Everyone they used to doubt got a day job. I just made a few stacks off a merch drop. It's about time that they go and take me serious. If you're not feeling this, you're probably delirious. I'm all one, yes, I'm all one. Think you'll never be with me.
Go straight on. Turn left. Ready, turn right. Turn left.